Okay, everybody, welcome. Welcome to our latest hashtag Saves Lives webinar. My name is Gaia Gamhavage, and I am the head of learning and capacity development at the World Health Organization's Health Emergencies Program. We run these webinars to have frank conversations, to stimulate thinking around key issues that are related to health education, public health education, medical education. And what better time to discuss this than during this unprecedented pandemic that we are all finding ourselves. I'm so grateful for everybody who has joined. I see we're getting up to 1,000 people live, and I'm now going to ask my colleague Andrea to post again the YouTube link if you want to send that to your colleagues so that they can follow as well. We're going to take about 90 minutes around a really interesting topic. But before we do that, let me get to some housekeeping. So we are going to have a live webinar. We have a great panel of experts who are going to share their views, their experience, their expertise on this really interesting topic. Will COVID-19 revolutionize medical and public health education? I'm sure you have a viewpoint, and I'm going to hear your viewpoint as well. We're going to speak with our 6 panelists, and then we're going to have some questions and answers. If you want to pose a question to the panel, and I must be honest, we have lots of questions usually, and I can't take them all, but it will guide me in what I ask them. Please write the questions that you want raised in the Q&A button at the bottom of your screen. If you want to make a comment or answer some of the questions I'm going to ask you, please write in the chat. Do we have that? So questions to the panel in the Q&A and everything else in the chat. We find that people write amazing things in the chat, and what we do is we analyze the chat after the webinar as well. So whatever you say will go in and feed into this thinking on this very important issue. You will not be able to speak, but you will be able to express yourself. All right, so before we start, let's see how engaged you are. Andrea, if you could help me with a little poll. So we're going to ask you a couple of fun questions. They're not scientific, they're not meant to be research, but they're meant to just get the temperature of the room. I also, so please feel free to just, I'm sure it's just popped up on your screen, pick the answer that is closest to what you're thinking. The first question is, what is the impact of COVID-19 on your medical or public health education? It could be you as a student, you as a teacher, you as somebody else who is in this ecosystem. Very interesting. So we've got nearly 500 people who've answered out of 1,100 who are live on the call. Gonna let it go for a little bit more. What an amazing audience. We're seeing people, India, Indonesia, Sri Lanka, Sierra Leone, Nepal, Philippines, Pakistan, Zimbabwe, Ghana, Nigeria, Canada, US, Jamaica, Bahamas. I don't know, the list is Kingdom of Saudi Arabia, South Africa, Iraq. It's amazing. Lots of people from the Philippines, Niger, Democratic Republic of Congo. Oh, we see Ukraine, Egypt, amazing. I'll just give a few more seconds so that you all get to vote. Italy, Iraq, Kazakhstan. What a diverse group. Vietnam, my goodness, Colombia, Mexico. All right, I think Andrea will end the polling in that question so that everybody can see the results. So 40% of you think that the impact is mixed. Some good came out of it and some bad. Very few of you said it had no significant impact. But 38% of you, right, more than 1/3 said it increased my ability to learn in innovative ways. So this is really interesting to hear. 1 in 5 of you did say it lowered the quality of education in those domains. Thank you so much. Andrea, if we can have the next question. It's going to be quick. I'm going to give you less time for this now that you know how to do this. What concerns you most about the current pandemic-related challenges to medical or public health education? Is it the quality of online learning that worries you? Is it the ability to acquire skills? Is it your ability to do practical hands-on work? Is it the ability to learn from peers? Is it more about inequities in digital access? Is it about the cost? Or is it about the social isolation that we are getting by not going to school? Or the slow response of school administration to innovate or harness new solutions to learning? So we'll take just a few more seconds. Go with your gut. You have to pick one. So I'm seeing ability to do practical hands-on work is leading at the moment. It's the lead horse in this race. Keep going. All this. All right. Oh, I see Armenia, Colombia. My goodness, lots of new countries coming on board. Okay, so really 40% of you is really about doing practical hands-on work. But 13% of you are also worried about the quality of online learning. This was not a multiple choice. You had to choose one, so I'm sure you have many concerns. 8% of you about social isolation, and about the same, worried about inequalities in digital access. Thank you so much. Last question, and then we're going to get going. So we have more than 1,000 experts now, okay, answering our questions. Next question. Simple question. The title of the webinar. Do you believe that COVID-19 will revolutionize medical and public health education? Just a yes or no. I see Australia, Zimbabwe, Tanzania, Chicago, Illinois. My goodness. All right, most people have voted. Let's just give it 10. Okay. All right. So whatever we mean by revolutionize, we believe that there's going to be some lasting changes. Now the question is, what? How sustainable? Should we have them? Is there something else that we haven't thought of? Lots of room for discussion. So we'll stop the polling. I want to thank you. I think about 1,000 people answered that last question. So amazing. I see that you're all awake, all caffeinated and fed and hydrated and ready to go. Okay, so let's get down to it. We're going to start with, I'm going to invite the panel to speak one by one, and then we're going to take some questions. But also feel free to send your comments, observations, feelings as they talk. We're going to start with Professor David Gordon, who has been with the World Federation of Medical Education, I think, since 2007, and been its president since 2015. He has a very illustrious past in research, academic and clinical work in Leicester, Cambridge, London. He's been with the Wellcome Trust. He was most recently the Dean of Medicine in Manchester, I believe. But today, really, we've invited him because of his dedication to standards in medical education. So Professor David Gordon, I'm going to call you David. I'm going to call everybody by their first names, if I may. As the president of WFME, you've led the development of standards and quality in medical education for some time, but COVID posed some new challenges, right? I'm really interested in, you sharing with everybody some of the work that the World Federation of Medical Education does, and what have you done in COVID? How did we get to where we are today? Over to you, David.
Thank you very much, Gaia, and thank you for the invitation. I'm delighted to be here. I think this is probably the largest audience I have ever spoken to, so it's a very great pleasure. The World Federation for Medical Education is the organization, the non-state actor that's in official relations with the World Health Organization and concerned with the quality of medical education worldwide. We've been around for nearly 50 years. We were founded partly by WHO and partly by the World Medical Association. And our concern as I say, is about quality, but not the detail of education. We're concerned with how the education is managed, how it is organized, how it's run, the relationship to the healthcare system, the relationship to the politics of healthcare and education. We're not primarily concerned with the detail of education, what the actual exact content of the course is. And there are many others who can talk about educational approaches and so on. We have three main programs, which you can easily find on our website. But what we are concerned about today is standards for medical education. My predecessors 20 years ago developed a program proposing standards for medical education, not a common curriculum, because anyone who's tried to do that, it just doesn't work. But whatever the curriculum, whatever the circumstances, we can say at what standard should medicine be taught, at what standard should students aim to learn, whether it's your processes for selection of students, the facilities that you need to have, or indeed your process for developing a curriculum or for working with the healthcare system. So we have standards for medical education, not just basic medical education, but education at the postgraduate level, taking graduates from when they qualify to when they become a specialist, and also standards for the ongoing, continuing professional development of medical doctors. Now, the first edition of the standards for basic medical education were published 18 years ago, and we have very recently published the third edition. It was at the end of last year, and those standards are a little bit more concise than the second edition, not a little bit less prescriptive. That's not a rule book, it's a guidebook. It says, if you're going to develop a curriculum, how are you going to do it? What's your approach to it? Rather than saying, you must do it this way. And I think as a guidebook, that's a lot more useful wherever you may be in the world. We've been pleased with the reception of that new edition of the basic medical education standards. I'm delighted to see my colleague, Professor Janet Grant, nodding, because I must give her the credit because she won't take it herself as the person who led the process to write the new standards. A few months ago, about nearly 9 months ago now, we ran a seminar a bit like this, but with a rather smaller audience. And we covered a number of issues to do with medical education during the pandemic, but it was very clear that the single most important subject for the participants in that webinar was the question of the delivery of education when not everybody can be in the medical school at the same time. How do you manage distance learning, and how, rather better, do you manage distributed learning? How do you actually get to students and staff who are not physically there? And because of the interest and the excellent questions we had at that seminar, we have now been preparing a new set of standards for distance and distributed learning. Janet led the team again, and those are at the final stage of consultation, and we hope they'll be published really very soon. So I think there we are. We're not setting rules, but we're trying to create tools that will help the development of education in these very difficult circumstances. Thank you.
Thank you, David. So, based on, I'm definitely going to go to Janet now. We're very curious as to what Janet is going to say. But before we go, I mean, as the president of the World Federation of Medical Education, what sort of challenges did you face during COVID-19? You said you had a webinar, people expressed their views. What were some of the challenges you faced in doing this work?
I think we've had some relating to other programs that we do. And for example, verifying the accreditation standards for medical schools is difficult to do when it's difficult to visit the medical school. But I think the single thing that has concerned us the most is that in some places, in some jurisdictions, in some settings, it has become very difficult for medical students to study with real patients. And indeed, at one extreme, we've seen people writing saying that students will never be able to see a real patient before they qualify. Now, that's obvious nonsense, because you've got to be able to see patients to learn how to be a doctor. And it's actually up to us to create circumstances where the opportunity to learn is actually taken and indeed is enhanced. very often, and we have this in history, medical students learn even better when circumstances are very difficult, because there's a lot of illness. You have to think about what you're doing more deeply than the way that you normally do. And so I think it's not a matter of running away from the possibilities of clinical education, but I'm delighted to find authors saying that it's in our nature not to run away from a difficult situation, but doctors run towards it to actually try and do the right thing. And I think that's the attitude, with safety, and of course, but that's the attitude we have to make sure we develop for our students as well.
Thank you very much, David. That's certainly my experience as a medical student and a doctor working in some complicated places. Thank you. So, the much awaited next speaker, Professor Janet Grant. Janet is she's actually the WFME special advisor and director of something called the Center for Medical Education in Context. And this last word is very, very important about context. She's an educational psychologist. In addition to being the director of CENMEDIC, she's actually, and I looked up this acronym, associated with the US Foundation for the Advancement of International Medical Education and Research. This is a long but very important name. She's honorary professor of University College London Medical School, senior scholar, Department of Medical Education, University of Illinois at Chicago, College of Medicine, emerita professor of education, medicine in medicine at the Open University, which is really a very long, illustrious career and a lot of learning from there. And of course, her current work with the World Federation of Medical Education. So Janet, it's a real pleasure to have met you through this process and to talk to you today. And you've led this work, these standards for medical education during COVID, and I'm sure it'll be applicable going forward. Tell us a bit more about this, and particularly this concept of distributed learning. And of course, I'm sure everybody's curious about how we can take standards and put it into particular contexts. So over to you, Janet.
Thank you very much indeed. I'm sure after that, I can only disappoint now. I shall share my screen. Oh, that's interesting. That's not necessarily sharing. Let me just try again. Oh, maybe the Zoom preferences don't allow me to share my screen. You do actually have a copy of my presentation, or I can do this without my. Can't hear you.
Andrea, can
you?
Yeah,
I'm sharing for.
Yeah, do you want to do that?
She'll do it on your behalf.
Yeah, I think there are probably preferences. I'm sorry about this, Andrea. You're going to have to.
No, that's Dr. Titi's, not that one.
That one's not me. You're going to have to keep clicking here. There's a lot of clicking in my presentation.
There you go.
Right. Okay. So thank you very much indeed. I can't move that. Can I move that on myself?
No. Yeah, I don't think you can.
No. Okay. So I'm just going to have to keep saying
yes,
and it's going to go on forever.
Yes.
So this is about the advent of distance and distributed learning. Next slide, please. Yeah. So I've been involved in writing all of the versions of the WFME standards, and I've also been involved in standard setting in the United Kingdom for regulatory bodies, particularly for postgraduate standards in the United Kingdom. So I direct a large international distance learning master's degree. I planned for the UK government and the General Medical Council an entire distance learning medical school. You know that I've been involved with the WFME standards, and I've established distance learning programs in medicine in the UK, in India, in Bangladesh. Next, please. So now you're going to have to keep clicking because there are lots of clicks. So will COVID revolutionize? Okay, stop there. Will COVID-19 revolutionize medical and public health education? My answer is I do hope not. because medical education has strengths. It's got necessary content in basic science, clinical skills, assessment, experience. Medical schools differ according to their mission, their context, their problems, and that requires contextual development, not revolution. And development should occur in response to an identified problem, not in relation to fashion. Medical education tends to move with fashion. That's A, dangerous, and B, unethical. Next click. And there is no robust evidence to suggest what innovations to adopt. Under those circumstances, revolution would not be a good idea. So what this does suggest is rational development. Next, please. So what changes have actually happened? Well, students are no longer located so much in the same place, but really they never were. There is the conversion of curriculum elements to virtual or technology-based methods, but much of that was actually happening already. And one of the things that worries me about that is the quality of that conversion. As one of the polls said, it's a technical skill to develop things for online learning. There has been a conversion and delivery model which was appropriate as a short-term firefighting response to a crisis. Just convert things to something that's online. That is not appropriate as a long-term solution, because schools didn't usually change anything other than their method in teaching and assessment. But if you're going to change your entire way of doing things, you have to change the entire school. But I've been impressed by the technical development of teachers and schools. I'm worried that these may be embedded at this level without further refinement. That would not be good. Next, please. So, if schools change their identity in the long term on the basis of what they've learned during this period, a different planning, implementation, and quality assurance process is required. Schools must adapt their planning, design, resource allocation, and management to distributed learning. It means that the school itself has to change, not just its teaching methods. The school in distributed learning must have a distributed presence, a local presence. It must appoint teachers who are near the location of students. It must set up regional branch offices for meetings, for study and academic advisors, and all sorts of things that distribute not only the students, but also the school. Next, please. That, of course, won't suit all schools. Some may wish to revert to their previous formats, and there is no reason why they should not. Next. So, distributed learning, what is it? Well, learners are away from the central institution, as they are with the Open University. We have no students on campus. Some regarded that as a joy. We have no learners on campus. They are everywhere and anywhere. The school incorporates facilities and staff near to where the students are to deliver the curriculum. It doesn't all come from the centre. It is distributed as well. And learners are supported both centrally and by local teaching staff. And the local teaching staff, which is another difference, are supported by the central institution as much as the students are. There's a rich variety of virtual, technology-based, and, please note, face-to-face teaching and learning methods and assessment. Distance and distributed learning is not online. It is distance and distributed and involves a serious face-to-face component. But this means that distributed learning is a managed whole systems approach. Next, please. And this suits medical education. If you think about medical education, it's already distributed. You've got a central medical school with all your academics and researchers and design and materials production and so on. You've got hospitals where there are clinical supervisors and teaching experience, clinical experience, student support, and everything. You've got community and rural facilities where we also send students with their supervision, teaching experience, all the same things. And then if this were a distributed or a distance learning medical school, we would actually set up local study centres, local resources, study spaces, meetings. This involves mapping not only the healthcare facilities, which is what we did when we designed our distance learning medical school, but mapping where your students are. Next, please. So, knowing all of this and seeing what was happening, and on the basis of what David said, responding to what people were asking us to do, we wrote WFME standards for distributed and distance learning, and these now will soon be out. And these set out the conditions for distance learning that is effective for teaching, learning, and curriculum delivery. There's a huge body of knowledge and experience in distributed and distance learning that sees this as a long-term development, not as a firefighting online response, that's properly implemented, effectively managed, that's a big word, and quality assured. And these standards were written by people with extensive experience of distributed learning. We undertook a wide consultation to ensure their clarity and relevance. And these will, we hope, be supported by training and consultancy that we can offer. Next, please. The WFME standards are principles-based, as David has already explained. We do not prescribe what should happen because there is no robust evidence in education to tell us what we should do, none. And also, context is important. What works in one context does not work in another. I think I've mentioned before to some of you, even the way in which we give feedback, it will work in one, some models work in one culture, some models work in another. So these are principles based. They will enable local design decisions. And they set out those design areas and the issues within them. And they offer key questions and guidance to enable schools or regulators to consider the application of these standards to their own context. Next, please. Rule number 1, I just add this in. If you're thinking about distance or distributed learning, forget everything you ever thought you knew about fashions in independent and self-directed learning. Forget it. In fact, generally forget it. Distance and distributed learning succeed when you take the student through a defined learning pathway and keep them there. If you lose a student at a distance, you don't know where they are, they've wandered off into the wild and you'll never get them back again. So this has to be a very carefully managed whole process. Management is the key, as it is actually the key to all education, teaching and learning methods and everything, isn't it? It's management. Next, please. So what must be designed and managed for distributed learning? Well, the WFME standards set this out. We look at the character of distributed and distance learning. We look at course design, course production, assessment, student support, academic and clinical staff, how you support them. I don't like training, I like support. Course management, quality assurance. We look at all of those issues and provide guidance about how to do this. Next, please. So, if there's a revolution in education, and I hope there isn't, just changing delivery methods is not enough, particularly if you don't do it very well, as our poll just showed. If schools choose to stay with distributed learning, and they can do because it can be done absolutely brilliantly, we need whole systems management, systems being the medical school and all of the distributed parts of that medical school, the pathway of the students, the assessment system. We need effective use of distributed locations, lots and lots of student support and lots of teacher support. We need quality assurance, and the most important of all, the most important person in our master's degree is our academic manager. And that's also true in the Open University. Next, please. So I'm coming to the end. How is distributed learning different from traditional learning? The students, the school, facilities, and resources are distributed. If you just think it's the students, that's not going to work. Central planning, management, and quality assurance of the distributed system are key. There is a different balance of technology, face-to-face and group learning, greater support for teachers, a central role for academic management and records, and a different balance of formative and summative assessment, greater student support. So finally, to end with some advice. Next, please. Never change, no revolution, unless you first identify the problem and plan an appropriate path to address it. Education is not a fashion statement, and in medical education, it often is presented as a fashion statement. Always put in evaluation, that is program evaluation, to track the effects of the change. There's no evidence base to help you decide what changes to make. Next. Never assume that students are natural online learners. They are not. They're good at the technology, they're good at games, they're good at looking things up on the internet. Learning is none of those things. So use traditional and new educational methods. And finally, support and management are the key factors. Thank you.
Thank you so much, Janet. I was listening to you and looking at the chat. So people really loved what you're saying. Actually, there was a very cute comment said they love your accent as well. So,
oh, it's just English, real English. Thank you.
Somebody really appreciated not just what you were saying, but how you were saying it. So fantastic, amazing. I think it's given a lot of food for thought. Thank you. And actually, we don't have a lot of presentations in these webinars, but we thought we would really make two exceptions, and the next exception comes up because it's part of the World Federation of Medical Education, but the president of the Southeast Asia part of this, Professor Titi Savitri is here to talk us through a regional perspective. She is, of course, a renowned medical educator. She is currently the president of the World Federation of Medical Education, and she's based in Indonesia. She deals with the Southeast Asia region. She's been actually for the last 25 years in this area, medical education, curriculum development. She has a lot of passion about curriculum development, quality assurance, medical education regulation. She has a lot of honors at national level, but also at regional level. And she's here to be really concrete, to share with you what they're doing in the Southeast Asia region, in this very diverse region of 11 countries. And she has some recent research to share with you as well. So I promise this is the last presentation, but Dr. Savitri, please, the floor is yours.
Okay, thank you, Dr. Gaya. Please allow me to share the screen. Okay, good morning, good afternoon, good evening for all of you around the world. 1 year ago, around this time, for the first time in my life, as a medical teacher for almost 25 years, I was forced to stop seeing my students. I was not allowed to go to my campus, to my own office. I was forbidden to meet in person, to have face-to-face meeting with my colleagues. All of a sudden, I had to move all face-to-face sessions into online learning. I had no clue at all how I could deliver my blog into fully online, but the show must go on. What happened was all the interactive sessions were delivered using Zoom application online. And I lost all the joy of seeing my students, of seeing their expressions when they were confused, of seeing their body language when they got the aha moments, and delivering lectures online was so dull. I believe that most of you who attend this event experienced the same moments last year, and we cannot pause the learning process. We cannot stop the medical education. It must continue. Medical education is one sector which cannot afford long-term disruptions, as it holds the formal responsibility of preparing human resources which are required to maintain the smooth running of the health system in a country. And I want to know how my colleagues in Indonesia, as well as in other Southeast Asian countries. So I would like to thank Dr. Gaya for encouraging us to gather the facts of what and how medical schools have responded to this COVID-19 pandemic. So in these presentations, I would like to share some stories in CRAME member countries with all of you. These presentations have been prepared by me and assisted by Professor Thomas from India. First, I'm going to introduce what is CRAME, and secondly, I would discuss about the methods, then followed by the results and discussions, ended by what we shall do next, because we don't know when this pandemic will be over, and we might not go back to our past. We must ready to encounter new challenges. So what is CRAME? It is one of the regional associations of WFME. It has 11 member countries: Indonesia, Thailand, India, Bangladesh, Sri Lanka, Bhutan, Nepal, Myanmar, Timor-Leste, Maldives, and North Korea. At the moment, we have 842 medical schools, and the biggest numbers are in India with 542 medical schools, and Maldives only have one. We have a lot of challenges. We have big disparities in the provisions of medical doctors and health professions. We can see from this picture, there is a huge disparity in the density of medical doctors and health profession educations. In Indonesia and Thailand, we have 5 times more nurses than doctors. And also here within the country, we can see also the disparity, the big gap between the lowest and the highest density. And these are our challenges. We have changing health needs. We also have new commitments in Sustainable Development Goals, also universal health coverage. And we all know that universal health coverage cannot be achieved without health workers. And we also have challenges involving the health workforce, the shortages, the unequal distribution, the rural retentions, adapting education to fit changing health needs, and the performance. And on top of this, now we face more challenges with the COVID-19. So we want to know what have happened and how the medical schools responded in CRAME member countries. So we gather the fact through online survey, and also we look at the published articles and reports from member countries. And from online survey, we had 132 medical teachers as respondents. We can see here that 48.6% they teach at the undergraduate level and postgraduate level. 20.2% teach the undergraduate year 1 and 2. 14.7% teach the undergraduate in clinical year. From the years of experience, 62.4% have more than 10 years of experience. 24.8% between 5 to 10 years. And if we look at by country, our respondents, 78.9% from India, and also we have from India, Indonesia, Thailand, and Nepal. And if you look at what are the level of competencies according to the pillar pyramid that they address. So 55% address the knows how, and 24.8% address the shows, 11.9% the does, and 8.3% the knows. And then we ask, what are the instructional strategies that they have used to achieve those competencies? And we come up with very interesting answers. There are more or less 20 different instructional strategies, from synchronous online lecture, asynchronous voice embed PPT lecture, asynchronous pre-class assignment, followed by online teaching in flipped classroom, interactive video, online PBL, scenario-based online learning, online group learning with feedback, video clip of role model professional behavior, very interesting, how most respondents still try to teach professional behavior. Storytellings by patients or family clinics, near peer learning, case study and presentations of family members, short video clips from YouTube and other learning repositories, feedback on video recording of role play or performance on simulated real patients in their neighborhood, case study peer review, real patient using PPE kits or COVID prevention protocol, training tutor pairing, tagging a doctor or resident on the job, standardized patients to overcome paucity of teachable patients, simulation lab, and then telemedicine, telehealth setting, live broadcasting of real patient encounter via Facebook. And if we look at here, we can see that most medical teacher, especially the knows how. Here, they use mostly synchronous online lecture. So most of the respondent address the knows how level, and they use the synchronous online lectures. And next, the simulation lab and interactive video. For knows competency level, here we see that most also use synchronous online lecture followed by asynchronous voice embed PPT lectures. For the DAS competency level, mostly they use feedback on video recording of role play or performance of simulated or real patients in the neighborhood. And if we look at the overall numbers from the instructional strategies that they use in facilitating the achievement of competence, 22% mostly they use synchronous online lectures, and 15.6% use online PBL, 12.8% simulation lab, 11.9% case study peer review, 8.3% video clip of role model professional behavior. And then we try to ask the questions regarding what is the method that they use called or known as, and then what are the activities or steps or learning experience for the students, strategy used to keep the students actively engaged in learning, any strategy for practicing skills and giving feedback on student performance, method to document progressions in competency development, also anything else that they want to share with us. And out of 132 respondents, we have got a variety of responses. So it is just difficult to get common themes. Therefore, for this presentation, I just cited some examples, like, for example, this one, respondent 1, regarding what it is named, no name given, and what activities that he did, prepared school schedule and posted, and then provided links for resources for student posted, self-directed learning posted, problem based on the topic of the week. Later posted standardized solutions to the problems. And then again, assignment was given and asked to submit within stipulated time. And then for the method to document progression in competency development, not done due to time constraints, and it can be replicated. Another example is respondent number 7. The name is called Flipped Classroom Teaching, and then activities is to update SES scale, and then assignment given to practice the skill using feedback during online sessions, and then method to document progression is online test, and other description is about high order online tests yet to be conducted to capture mastery of the skill learned. The entire exercise may be split into pre-recorded mode and shared through a website or blog with link to access the same shared through WhatsApp, so that students can do the exercise at their pace, and the higher order test can be conducted and results shared immediately. Feedback to the batch be given shortly after this by focusing on which part of assignment went well and where they should pay more attention to. This is another response from
So,
respondent
Dr.
number 13.
Dr.
Yeah.
Siti, we will make this available to everybody, in the
Yes.
details, yeah.
Okay. And also, we have from some of our colleagues published their comments on the journals regarding the outcomes of COVID pandemic on the medical education, which have impacted all stages of medical education, and also express the need to maintain quality with less flexibility in training time. Also, classroom-based teaching can be supplemented with online distance learning approaches, and so on. And also, we look at the country report. For example, in Nepal, they experience quite challenges because they have a drastic impacts on the career progressions of current medical students. They have lacked dependable internet services to support medical educations, which frequently require access to and transmission of large files, also transmission of audiovisual material. And in many countries in Syarame, students also are poor, physically disadvantaged, and they do not have a home situation conducive to online study, and this can affect the quality of the medical education they get. So what are the recommendations? Of course, this is really the time is open for us to revolutionize the medical education, although Janet Grant does not agree. But we need to take this momentum to really rethink about our medical education as well as the virtual clinical learning, because after the pandemic is over, which we do not know when, we might not get back to the past. We will face a new normal. And from our respondents, we have this request to the CRAME and WHO. First, about the faculty skills development programs and access to technology resources, participate in communities of practice, scholarship for fellowship programs. So this is really a need to rethink and to minimize the risk. So we need to work together in order to redesign, redevelop our medical educations, and then as well as to embrace the quality assurance and technological advances. Thank you very much for all your attentions.
Thank you
I
so
think
much.
that's all.
Thank you. Thank you so much. Yes, you see a lot of comments are coming in. So we went from the global perspective to the regional, and we moved to another region, but to a country where I'm going to introduce Dr. Asim Mirzazadeh. He's the Associate Professor of the Department of Medicine and Department of Medical Education in the School of Medicine of Tehran University of Medical Sciences, and you can see a picture from his university behind him. It's a pleasure to have you, Dr. Azim. I know you also spent a couple of decades at least in this area, undergraduate, postgraduate education. You've not just worked for universities, but supported the government, Ministry of Health, and you've really been involved in the several accreditation systems for both undergraduate and postgraduate medical education. So I'm really curious to know, how you in your country and in your faculty, how you've approached this. How have you approached it? What have you seen? What have you done? What are you seeing? What is the perspective from your country? Over to you, Dr. Azim.
Thank you so much, Dr. Gaia. And it's my privilege and honor to participate and contribute such wonderful event, as David talked about before, about the huge number of colleagues who attended and really experts all around the world that contributed to this webinar. Because for the sake of time, I rapidly moved toward some talks about our experience at the country level and also at the Medical School of Tehran University of Medical Sciences. First of all, it's so interesting to me because I feel that we passed grief reaction phases during this pandemics, from denial and anger to bargaining, depression, and acceptance. And I'm not sure all of us is in the same pace in such reaction phases. Some of us might be even in denial phase, even 1 year after the starting of this pandemics. And it's not enough time to describe the details of this grief reaction phases and what happened in my country. I think that it is the same to many other regions and countries and even globally. As general challenges, just to pick some of them, I think that the educational system in my country was absolutely unprepared for such a disaster at all levels, from the top administration to the student level. It's not so strange, because after 100 years from 1920, there is another pandemics with coronavirus after Spanish flu. The uncertainty about many aspects of the pandemics, this disaster is so different from an earthquake or from a big fire in city, because mode of transmission, prevention, treatment, and end of the pandemics are not so clear for many of us. The confusion, fear, and hopelessness could be seen around the medical school in all levels. The shortage of PPE, at least in first phase, was a major challenge, and also ethical and professional challenges. What's the role of medical students as a care provider? Is he or she a student? Is he or she a doctor or a member of health profession that should provide care? It's a major challenge for our system, and we had some troubles about it. Insufficient human resources to handle all stuff during such a short period. It's not clerical staff, those who have expertise in medical education, as Janet talked about the importance of have a holistic view of this change, not only on the teaching and learning methods, but also on the planning and assessment and support, and also technical staff, and also about insufficient resources to move through our distance distributed learning. We have several challenges in curriculum development and also in teaching and learning and assessment. I have not enough time to talk about every aspect of these challenges, about the different steps of curriculum development. We need profound changes, and also about all the phases of the curriculum. We had several challenges. It's so interesting to me that as I remember, for the first time in my career as a general internist that works somewhat in medical education, that all physicians' competencies were under pressure. Clinical skills during pandemic, communication skills when you wear masks and you didn't right to touch patient as possible, about the patient care, about the rehabilitation, about the emotional support of patient, not only providing some medication, about the professionalism, why we should provide care to the patient and anybody else should do that. The personal development, about resilience, about health, mental health, about physical health, about the disease prevention and health promotion. The major challenge for all medical schools that to convince medical students that disease prevention and health promotion is important, at least as treatment and medication. And this pandemic shows the importance in real world about reasoning, evidence-based decision making, and about physician roles in health system. Most of us have to be a leader, even in our microsystems, and it's not a small challenge for most of us in hospital settings and etc. And I should move to what have happened at the national level. The Ministry of Health and Medical Education, that, as you know, we have an integrated system between medical education and health system, health department. They require policy and procedures for letting medical schools to adapt to the pandemic based on local situations, has been released by the ministry and those who related to education, providing some sort of requirement resources, for example, a universal LMS for all medical schools all around the country with different levels of financial resources to use it for asynchronous teaching and learning, and also providing financial boost to help medical schools to handle the situation, and is not so small in such circumstances. About the university and school level and teaching hospitals, expanding require online platforms, just Zoom, Adobe Connect, Big Blue Button, and also we develop a domestic platforms to provide for all medical schools and all faculty members. Huge efforts for staff development, how to work in new platforms, how to provide education material for asynchronous and also for synchronous education. It's not so simple for faculty members to work with Zoom as a presenter, not as a participant. Providing PPE for students. All the students receive PPE for day-to-day work in the hospital, if they allowed to be there. And also equipment for education activities. The most important issue was developing or letting departments to develop policies and procedures to handle new educational experiences. It's so important because you need new policy and procedures. You should develop it to handle the situation. Not sufficient to provide some synchronous or asynchronous platform to faculty member and to let them to do anything you need. As Janet talked about the importance of showing the pathway toward learning. And also telehealth platform we developed for providing care to COVID-19 patients. And we used it as an educational platform for our students with supervision of faculty members and also residents. I am near the end of my talk. And about the departments and wards, all didactic sessions converted to asynchronous one. We try to have some synchronous sessions beside the asynchronous, sometimes successful, sometimes unsuccessful in different phases. And also we try to maintain, as David talked about, the importance of being there in the hospital to handle patient, to learn medicine in the context. Therefore, we try to maintain as much as possible for face-to-face of our clerks in clinical rotations with different means, decreasing the time of encounters, decreasing the number of clerks, providing PPEs, and also deleting the new COVID VARs from the clerk clinical rotations. We also developed several educational meetings. It's wonderful because virtual ground rounds, virtual teaching rounds, virtual workshops such as communication skills, history taking, and professionalism in online platforms, virtual case-based discussion, morning report, or noon or evening report. It's so interesting for all of us. And we have some experiences with whole 4-week rotation, for virtual 4-week rotation for our clerks in some departments. But for future, I think that we need reflection and action, and more importantly, reflection in action. We need it. We should not be Dory in Finding Nemo animation. As you know, Dory in Finding Nemo is lost each memory every second. And usually we missed our experiences just after finishing the COVID. And it's a major danger for us. We should be ready for new disasters like next pandemics, or in my country, severe earthquake. It's a real problem for all of us. And therefore we need policy and planning just now, not after finishing the pandemic. Thank you.
Thank you so much, Dr. Asim. And I can see a lot of things that you're saying is reflected in Dr. Titi's research findings as well. You see, as we're getting towards the front line or the field level, we're seeing similar challenges, similar experiences. Thank you. And you made a really interesting connection between clinical education and then the health system, the public health system. And we're going to move very soon into looking at the public health response because Dr. Michelle Yao is waiting for us. But before we do that, I think we need to hear from the medical student perspective. And of course, there are millions of medical students in the world, but there is somebody very special joining us today, Abdullah Al-Kaf. I'm so sorry if I'm mispronouncing your name. I know you're finally a medical student in Baghdad College of Medicine. You've, in addition to your medical studies, you've been working in student advocacy for medical education at national, regional, and global level. And within the IFMSA, which I believe has 1.3 million medical students from 134 countries, your work focuses on being you're the liaison officer, medical education issues of IFMSA. You focus on the health workforce crisis, open science, global health education, amongst other things. So I'm really personally curious to hear from you. What has been your experience and what are other medical students telling you as in your role in IFMSA? Welcome, and the floor is yours now.
Thank you so much, Dr. Gaia, and to your colleagues at the WHO for this opportunity. It's a pleasure to be among this brilliant panel of speakers and brilliant minds in medical and healthcare education, as well as among our participants, and Ramadan Kareem for all those celebrating. So as you mentioned, I come from Iraq and the University of Baghdad, and some of the things that have changed throughout the time of COVID for me, I believe I share with a lot of medical students worldwide. And we have majorly lost a lot of elements in our learning. And among those are communication, which could be further specified as communication with patients. It's basically the main component of us learning about enhancing our communication skills. And the world was shifting towards a reality where patients are more involved in the education of students, and patients could potentially create a solid partnership with students towards the future of education and in the healthcare career. Another valuable asset that we are losing is the communication with the faculty, which eventually impacts how we are being assessed, how we are being evaluated, the feedback element that is the most necessary for a medical doctor to be fully prepared to go through the real life of a doctor. I think we are losing that, and overall, when we zoom out, we are losing some, let's say, valuable component of our progress. And also we're losing the communication with other students, and we're losing peer education as an effective tool to practice clinical and practical skills, and we are losing the valuable asset of meeting with other healthcare students and promoting interprofessional collaboration in education. Clinical exposure is definitely one of the most, if not the most significant asset that we are losing. And in that specific term, I don't think that a medical student will be able to learn specific skills like inserting a catheter or performing a laparoscopy or even examining a diseased patient to observe specific signs of that specific disease that you cannot possibly learn via the online facility. And even practicing OSCE exams in the hospital settings. So, and also in addition to that, the lack of preparedness in the infrastructure-wise, the lack of PPEs, and one very important thing is the mental health of students that has been heavily impacted by the online transformation. Just like Dr. Grant mentioned, just because we like technology and we are good at it doesn't mean that necessarily we like being educated virtually. So it has definitely impacted students' mental health. And overall, when we look at the bigger picture, we are losing the fact of the engagement component. Students are less engaged in their educational process overall. So among the other challenges that could be a more global are the fact that adaptability has been varying vastly among countries worldwide. In terms of emergency preparedness and infrastructure, some faculties managed to have a very fast transformation of their education towards the virtual setting. And some faculties I know, like personally, had only 24 hours, like one day, to transform their whole setting from a physical classroom to an online classroom, which in a way or another definitely impacted the quality of education. While on the other hand, some faculties took a very long time and they had a very slow adaptability to the new setting. Let's say that, and this is not by anyhow an offense to teachers, but this is a reality. Some teachers, a lot of teachers are not acquainted to technology. They do not like technology and they do not like to go there. They do not like to explore. And this is definitely a barrier towards innovation in medical education. In addition to that, there is the reputation factor, or how doctors and health workers are being perceived by the public. And a personal experience that I had, that I have been, like, me and my colleagues, we have been called as the COVID doctors or the online or virtual doctors. And I believe on the long term, this could impact the health worker slash public relationship, and will definitely impact the trust between those two parties, and hopefully this will not damage the health outcomes worldwide. um, mental health, I keep stressing on this because this is an area that is oftenly neglected, forgotten, ignored for any reason. And a lot of medical schools just let their students go there and practice in a hospital that is full of COVID patients without providing enough protective measures, which in my humble opinion could be not the most responsible behavior by an administration. um, expenses of education didn't change much, and unlike expected. Like, we are moving towards the virtual learning, people are studying from home, but a lot of schools didn't change the cost of education, which is also another challenge. And it could be not very correct to think that virtual learning provides equity in healthcare education, because we have another inequity, which is the internet inequity. Broadband width is not the same among countries, and internet speed is not similar in different regions. And this factor has also been neglected even by educational platforms and technologies. So how different the past COVID medical education and healthcare education will look like, I guess we should leave that to time. But as students and as IFMSA, we call for, we demand, we would like for students to be more engaged. This has been an issue, this has been a challenge for a lot of years. Students are not yet adequately engaged in their education and in decision making in medical and healthcare education. But I think COVID gives us the ideal opportunity. I mean, let's just all sit together, gather around, and really get inspired by COVID and learn from COVID and learn from the lessons we learned from COVID, and then just try to avoid any mistakes that we have made. Um, and we in IFMSA, of course, we continue to advocate for student engagement towards decentralized, accessible, equitable, high quality, and student-based medical education and healthcare education. Thank you so much.
Thank you so much, Abdullah. And what you were saying about grasping the opportunities is a full circle as to where David said, you know, medical students, doctors, we run towards the problem and we have to find the solution. There's such richness in what you said. Thank you so much for your honesty and your frankness, because I too have heard many of the things that you have said, in different fora for learning, and also from medical school students directly. Last but not least is Dr. Michel Yao. Michel is a medical doctor. He was born in Côte d'Ivoire. He's Canadian. He's done clinical medicine. He's been a lecturer. He worked formerly in the Red Cross. And in 2004, I met him, because when he joined WHO, and he's had an amazing career in WHO. He's worked in our regional offices. He's worked at head of country office in some of the most difficult places in the world. In fact, I think he was a decorated commander in the Order of the Central African Republic for his services there. He led our response to the Ebola outbreak in Democratic Republic of Congo, amongst many, many other things. And most recently, since last August, he's been the director of the Strategic Health Operations. That's our response, and the response that's managing the COVID outbreak now. And so it's an absolute pleasure. But what you won't see in his CV is that he's a great teacher. And he and I have had nearly 20 years working together, training people in the field for health emergency work. Michel, it's a pleasure to have you. So I suppose we need to shift to public health, right? We are in the middle of a pandemic. How does education play out from your point of view? We are a public health organization. We're not a medical education organization. What have you seen? What are the big issues out there in the public health response and the education that is required for that? Over to you.
Thank you very much, and a real pleasure to be here with the professors. It's a reminder of many, many years behind where we were in the medical school learning. So in fact, is a starting point from the university. You have to have some background if you want to continue in public health. And the actual COVID outbreak quickly highlight gap in public health emergency workforce. So because people, we have many clinicians, but as COVID teachers, it's a much more comprehensive approach requiring different health determinants to deal with COVID. So I will say that in the emergency field, it's like a bit in the army. Most of the time, yes, you can learn in the field, but at least you have to get the basics. The basics is to ensure that you can hit the ground running because it's a kind of protocol that you roll out. It could be the same maybe in the emergency room, but this is about the population health. So you have clearly to know how to do, for example, an investigation, how to set up a concept of operation, how to even lead the response, the leadership component, including planning, strategic planning. You are a kind of, I used to say, the engineer of the response. So you analyze the situation and then you design the response that fits with the situation. And in this COVID, we notice also that due to gap of knowledge or skill in this area, at least some of the countries started by just copying what is done elsewhere instead of analyzing deeply what is happening in the country and providing a kind of solution, public health solution to it. So for all this, of course, starting by medical doctor, nurse, but it's required an additional education just to perform all these different services. Now there is another area that is more or less common. We can see in COVID, many people working in intensive care units. There also the colleague, our student, young colleague, mentioned the issues related to the well-being of people working intensively in this kind of conditions. So people were not prepared before. So it's bring the issue. Professor Janet was saying that we keep the same way of teaching, but in addition to the way of delivering the curriculum, it may require some innovation. It starts to add on different components that were not there, that is now highlighted as major gap in the education, like preparing people to work in a very different context, intensive context, and also to work fast, to think fast, to innovate, and to find solutions. In some of the settings I work in some of the developing countries, sometimes you have to create a system to deal with the crisis. So these are the key points. If I still have time, if you have another question, I can continue to elaborate on other points.
Great, Michelle. I think you're touching on something that came up and also in the chat and in the questions, you know. So you need your basic education. You need to have had that. It has to be solid. But in the middle of an emergency, we need to skill up or help people manage extraordinary situations. Yeah, and the pandemic has shown it's not intensive work for a day. It's intensive work for 2 years now. Right. So this is the same whether in a hospital or you're in the field, there are some added issues. And lots of people are writing and saying, you know, there's also transversal skills that are required. Communication skills, resilience, you know, managing complexity, managing conflict. And you yourself have run public health operations in very insecure locations, you know, 30, 40 armed groups, our own staff being killed. So just talk a little bit about some of the work you're doing to create a global emergency health workforce. You know, not taking away from formal medical and public health education, but what is your vision for that proposal?
Oh, thank you very much. From the last major crisis, we had the huge Ebola outbreak in West Africa and the ongoing COVID. We quickly noticed that we have some gap. Even if we have many medical doctors and nurses, but they lack some of the additional skill that is required to work in emergency. So the idea is why don't we give them an opportunity for a kind of for them to register into a platform, so a self-registry. And then from this registration, there will be offered a curriculum, a learning pathway, I may say. From this learning pathway, they will be certified in the area where they want to perform. So it's the learning components, the belonging to a kind of community of people doing the same thing, and then give also opportunity for mobilization. So it will, one of the outputs will be a database that will be available to member states, so they can be used in their own country, or some of the partners, including WHO, can use them, deploy them to support another country in the region or even out of the region. So it's an individual initiative, it's self-reporting, but the thing is that it had some incentive that you are part of a bigger group, you are offered training opportunities online. Some of the institutions will collaborate with them to offer some of the specific training, because the curriculum will have the core component that is related to emergency, what you just described. What is the coordination mechanism in the humanitarian work? What are the incident management system, for example? So these core things will be across different areas, but then they will have a specialized area. If you want to be involved in treatment center for cholera, for Ebola, these specific training will be offered online or by some of the institutions, and then people will be tested. When they are deployed, they will be assessed, and then at the end be qualified. So it will be an opportunity for career also be certified that you can work in the emergency field. So it's one of the initiatives I'm working on with Gaia. We will make it live in the coming weeks. So it will be really open to the world. It will help us at least to give this additional skill that was missing. As we are talking also about training, I think as a medical doctor, you can have many opportunities in the emergency. It could be dealing with epidemic or humanitarian crisis. You have different areas. You have the epidemiologists that everybody knows, but you have also infection prevention and control. You have risk communication. You have operational research, you have occupational health, taking care of those people going under stress or being injured into operation. And then you have the leadership component that is mainly people who coordinate. You have also in the humanitarian field what they call the health cluster coordinators. So there is a lot of opportunity for a kind of specialization or professionalization after the basic training. Thank you very much.
Thank you so much, Michelle. And in fact, you know, I want to just share a little bit because in 2014, West Africa Ebola outbreak, I was the international training coordinator. And the powers that be told me I have to train 106,000 people in 8 weeks. So of course, you know, as David said, we run to the problem. I said, yes, of course. But of course, we did it by coordinating and bringing everybody together, not claiming credit that we did it ourselves in WHO. But that led us to establish the openwho.org platform. For this pandemic, this put us in good stead, not to address all of the learning needs, but some of the learning needs. So as new guidelines came out, we very quickly transformed that into learning. And to make it accessible, our platform has, you can use it offline, there's low bandwidth, plus we offer courses in more than 50 national and local languages. So Bahasa Indonesia, Swahili, 3 types of Swahili, even sign language. So this accessibility is very important to us. And I'm sure that Andrea will put the link up. And if you are clinical, medically educated, there is a whole channel just for the clinical management of COVID-19 for vaccinators. So, you know, in a way, what I'm saying is we all need to come together to contribute to this lifelong learning that we all need. If I sort of take us back and refresh us, so David, you really talked about, you know, the importance of setting principles and the challenge of balancing a principle and a strategy at a global level, and you know where Janet was going. How do we contextualize that? And she really, Janet, really, you very succinctly but very effectively talked about, you know, what is distributed learning, and very good. You challenge. Are we going to revolutionize? Well, what I heard from you was we're going to have to. It's not a revolution, but it's an evolution. But it's an evolution that must be done based on proper analysis of what's needed and not just limited to techniques and method of delivery. And then when we went to the Southeast Asia region, you know, Titi's research with her colleagues was really useful because we can see what is the profile, what are the challenges, what is immediate, right? But again, I want to infuse what Janet said about managing this process. This learning pathway is as important as looking at the tactics and delivery. We went, Dr. Asim, really very, very, very thoughtful, very comprehensive about and going well beyond delivery of medical training, about how people can actually serve in the public health system, you know, the other things that are required. Really, really, and you talked about pathways, soft skills, and you talked about reflection in action. Again, tying back to what Janet said, you know, are we reflecting? Are we learning? Do we know the problem we are addressing? And of course, we went to our own medical student, Abdullah, who was very, very eloquent. I think he spoke for himself, but he spoke about things that I've been in many conferences with young people, not just medical students, and what you're saying resonates, right? It really resonates, and we must not underestimate the impact of isolation from each other, from the institution, from your teachers, the ability to get informed feedback so that we can move forward with confidence, and the potential stigma that you might be called a COVID doctor. I totally agree with this. This is not nothing to be laughed at. And Michelle, really going to this big complex world. So, what needs to be done? Who does it? How do we sustain a response? What are the additional skills we have? We're nearly out of time, but I'm going to ask you each for a very quick 30-second to 60-second reflection. Looking into each of your crystal balls from your perspectives, your own perspective, you don't have to agree. Looking into your crystal balls to look at the future of medical and public health education. What one innovation excites or idea excites you most? And what one issue concerns you most? Some of you have already said it, but I'd like as a wrap up for you to say that. So I'll go in reverse order now. I'll start with Michelle. What excites you most and what concerns you most?
What excites me most is what I said, learning from COVID to reflect on what additional is required for any medical doctor in any corner of the world. What additional skill you need to have to manage this kind of emergency, because it's one of the critical elements in the response to COVID, having the manpower that is qualified, that at least can go beyond the initial knowledge and then face the different related challenges. What concerns me is that is what has been said, is COVID should not dilute or change the way medical education is provided. It's about looking at patients, it's about sometimes hearing, also touching to learn what to do. It cannot be done remotely as in many professions. And so it could be also an opportunity during this COVID to introduce, I think in many countries it's done, medical students at least to experience this pandemic. We hope it won't come regularly like in the past, but at least they will experience something that is unique that can also serve in the future.
Thank you so much. We go to Abdullah. One thing that excites you, one thing that concerns you.
Yeah, I agree with Dr. Michel in terms of that COVID is a time for reflection, and the era of COVID is the era of opportunities, and it's like we have an open door of opportunities of a variety of options that we can together explore and perhaps reshape our provisions towards education, towards healthcare and global health. What could be a concern for me from a youth perspective is that young people have been struggling with tokenism for several years, for decades, and have not been treated as equal or not being treated as knowledgeable or have their own expertise. And I'm afraid that moving towards the online setting could amplify or expand the gap between the leaders, the administrators, the stakeholders, and the young people. However, I'm optimistic that my fellow young leaders worldwide will be able to mitigate this gap.
Yeah, thank you so much. Dr. Azim, what one excitement and one concern?
The most things that excite me during the pandemic is new ways of networking and learning.
Mm-hmm.
It's so interesting to me that we as human beings are trying to tackle this challenge with networking. This meeting today is another example of this networking, and even at the national level, at the institutional level. And also the passion and enthusiasm that those who involved in handling the disaster, the pandemics, not only on the side of education, but also on the side of healthcare. It's so interesting to me. But about the concern, I missed it in my talk about my serious concern about the quality of education. Despite all my talk that devoted to the initiatives that we started, I am seriously concerned about the quality of education that we offer to our medical students. It's a major challenge, and also about the emotional support that we provided to them. That's it.
Thank you so much. Let's move to Dr. Savitri, please.
Okay, thank you, Dr. Gaya. So this COVID pandemic has made me realize that the medical education program that we have been doing so far is quite rigid. You know, we are busy with calculations of credit hours, of staff-student ratio, of what are the equipments, etc., the buildings, all, you know, all those accreditation measures are very rigid, quantitative. So with this pandemic COVID-19, I think we need to move to more flexible medical education programs, more personalized learning pathway. And also learning can be done anywhere, anytime at the student space because they are everywhere. Therefore, collaboration is a key, and we should see medical education as a system. Before we see it's a fragmented, you know, medical education under the Ministry of Education, hospital under the Ministry of Health, and you know it's very difficult to get collaboration. But now we have to see it as a system, you know, together with all the stakeholders in the area. And secondly, this bring challenges for the quality assurance and accreditation. So I agree with Janet to have a more principle-based standard, and we need to move away from rigid and to prescriptive accreditation measures. So I think we need to tackle these two things. Thank you.
Thank you so much. Janet, your turn.
Sorry. To begin with, to start with the concerns, what concerns me is that this firefighting reaction of just turning everything online will become the status quo. That will not do at all. And that the focus on teaching methods becomes the focus. That also won't do. Online is just a teaching method. You wouldn't change a whole course to lectures. So I think people don't know what they don't know. They won't know that in the Open University, our students get more feedback, have a greater sense of group identity than in other traditional circumstances. So I think that the big and exciting challenge is for us to explain and to get people involved in redesigning the whole of what the medical school does and how it runs, and to start from the beginning in curriculum planning, curriculum design, and using our resources appropriately so that distance and distributed learning becomes a thing in its own right. As long as we think about it as online learning, we have lost the game.
Absolutely. Thank you. Very clear. David.
I'll just say quickly that I certainly agree with everything that Janet has said, but I'll say one thing that makes me very optimistic. And I think that the important thing is that if you look at the response to the pandemic generally, or the response of medical and healthcare education in particular, the thing that really works is when those are led by the profession who understand what they are doing and are doing their best for the people we serve. And I think the way that this is professionally led is extraordinarily encouraging. Thank you.
Thank you all so much. I realize we're 5 minutes past our time, but do you know that out of the 1,500 people on this call, 1,400 stayed. Now, this is a statistic. So I want to thank all of you. There was no solution to be had here, but there was a conversation to be had. And I think we had an amazing, diverse group of people, not just on the panel, but in the audience. And I'm just astounded. I'm waiting to read all the comments. In WHO, we are trying to look at public health education, not medical education. But I want to thank Dr. Titi Savitri, because she's the one who pulled us into this. And she said, no, we need to talk. Let's talk. What's happening? So WHO can only bring its convening power and do something like this. At the same time, we are trying to develop the first ever global learning strategy to shape the future of public health. And not public health methods or interventions, but to address public health goals. So I think some of the ideas that are coming from there, taking an ecosystems approach, looking at equity, looking at what the problem is, and not letting the tool lead the solution. Right? Tools are there for us to use. And there are many things, important things that we just touched on: inequity, lack of access, how we are, substituting a method for the whole holistic view of this. And of course, networking, ecosystems, not just the education, accreditation part of it, but the experience of people in it, both faculty, students, future graduates. And then speaking to Dr. Michelle Yao, how do you continue that? So great, you're a doctor. How do you continue to contribute, not just in your continued professional education, but when the world calls on you, like in a pandemic? How do you scale up quickly, safely, and really answer that call of service? So thank you so much. I think we're just going to say a collective goodbye to everybody. It's 37 minutes. It's 7 minutes past, but 1,300 people are on it. We will send you all the link to all the materials, to the recording. Please continue to join the conversation. We're going to have a lot more hashtag Learning Saves Lives webinars. And just to answer your question, no, this webinar, we did not set learning objectives, and therefore we did not want to give certificates. So I wanted to be very strict. I'm very sorry if I disappoint you. Conversations are part of our education, but not all of our education has to be certified. So with that, I want to thank everybody.